Have you ever stopped to think about this really uh, counterintuitive idea? What if, in some really extreme situations, making something harder to get or harder to use actually makes someone want it more?
Yeah, it sounds completely backwards, doesn't it? Goes against, well, basic supply and demand as we usually think of it.
Exactly.
And it really gets to the heart of why some big social debates feel so intractable. Like people are arguing from totally different planets sometimes.
Right.
And our deep dive today tackles one of those, a really contentious one, drug safe consumption rooms. You might know them as safe injection sites.
Oh, yeah. Few topics generate quite as much heat.
For sure. You get arguments flying from, public health angles, social impact, deep moral questions, and of course, what taxpayer money is going. It hits all the hot buttons.
So, our mission today for this deep dive is to try and cut through some of that noise. We're going to unpack this whole thing using a pretty surprising economic idea, one that's often overlooked in this context.
hmm It's a lens that gives, I think, a much more nuanced view on when these places, DSCRs, might genuinely save lives.
And also, maybe when they might backfire or cause other problems. It's about getting past the easy answers.
Definitely.
But okay, before we jump into the economic twist, let's just quickly nail down what we mean by DSCRs, just so everyone's on the same page.
Good idea. So basically, these are supervised places. People can bring illicit drugs they've already obtained, typically injectable drugs, that's the most common model,
Right.
and use them there. The key is they provide clean, sterile equipment, needles, cookers, whatever's needed right on site. And usually there's medical staff or at least trained personnel present.
And the main goal, this is crucial, right? It's harm reduction.
Exactly. The stated aim isn't to encourage drug use, it's about making the use that's already happening safer for the individual and, by extension, the community.
Okay, so with that definition clear, let's look at the case for these sites.
Well, the proponents, they're not naive. They understand addiction is incredibly complex, a real beast. Their arguments really come from a place of public health pragmatism, acknowledging a difficult reality that exists, whether we like it or not.
And the arguments are pretty specific. Like, first off, stopping disease spread. That seems huge.
Oh, absolutely. Think about HIV, hepatitis C.
No.
These spread like wildfire when people share or reuse dirty needles because they don't have access to clean ones.
And that's not just about the person using, right? It affects partners, maybe families. The wider public health system bears the cost.
Precisely. So DSCRs act as a barrier there, a crucial one. Then there's overdose prevention.
Right, because staff are right there.
If someone overdoses, staff can intervene immediately, administer naloxone, call emergency services if needed. This directly saves lives. The data on overdose reversals in these sites is pretty compelling.
And what about the argument that, well, people are going to use anyway?
That's a core point for supporters. The hard truth, they say, is that someone with a severe addiction isn't likely to stop just because there isn't a safe place.
So denying the space just pushes the behavior elsewhere.
Exactly. Into alleys, public bathrooms, parks, places where it's much riskier for them. Overdose risk goes way up, infection risk too. And let's be honest, it's more visible and disruptive for the community when it happens in public spaces.
So the argument is DSCRs manage an existing reality in the least harmful way.
Kind of, yeah. It contains it, makes it safer, reduces the public nuisance aspect. And ultimately, proponents argue this protects the whole community, preventing disease outbreaks, reducing visible public use. It's framed as a collective benefit, not just helping the individual user.
Okay, that all makes a certain kind of pragmatic sense. But then you have the case against DSCRs, which is also really powerful and comes from a very different place.
Absolutely. And these counter-arguments often tap into some deeply held moral and philosophical beliefs. They raise equally valid concerns, just from a different perspective.
And the biggest one you hear, the core fear, seems to be about enabling or even encouraging drug use.
That's right. The worry is that if you provide a safe, clean, supervised place, you're essentially saying this is okay, or at least less bad.
Lowering the perceived risk.
Opponents argue that could lead to people using more often, or maybe it could even attract new users who might have been deterred by the dangers and the stigma before. It makes it seem easier.
There's also the argument about misplaced focus, isn't there? That the goal should be zero use, full recovery.
Yes. A strong belief from many opponents is that every effort, every dollar should go towards prevention, towards treatment, towards helping people get clean and stay clean.
So spending public money on a facility where people actively use drugs feels backwards to them,
Yeah.
like a betrayal of that goal.
Exactly. Which leads directly into the taxpayer money argument. Why, they ask, should public funds facilitate an activity that society generally agrees is harmful and wants to stop? It feels like a contradiction.
And there's a related concern about normalizing addiction.
That's a big one, too. The fear is that having state sanctioned facilities reduces the social stigma, the disapproval around drug use. And if you normalize it, does that lead to wider acceptance, maybe more experimentation, especially among young people? Does it increase overall demand in the long run?
Wow. Okay, so you really see how both sides have these deeply felt compelling arguments.
Totally. And they often seem to be talking completely past each other, using different frameworks, valuing different outcomes. Both sides feel they're right, and in their own way, they often are.
Which is exactly why we need a different way to look at it. And this is where, believe it or not, economics comes in, but maybe not the economics you learn in school.
Right. We need a slightly unconventional economic lens here, one that forces us to pause and just for a moment challenge some basic assumptions about supply and demand when we're talking about these extreme deviations.
Okay, I'm intrigued. What are we talking about?
Well, economists have a term, sometimes called a Giffing good, which is pretty niche and debated, but we're going to use a related idea and maybe a more intuitive term for this context. A cornered good.
A cornered good.
We like that term because it really paints a picture of the situation, the desperation involved. It's not just an abstract theory. It taps into something very real about addiction.
Okay, so before we get to the cornered part, maybe explain its relative.
Yeah.
You mentioned something called a compelled good.
Yeah, let's start there. Think of a compelled good, sometimes called an inferior good in standard economics, but compelled fits better here. Imagine a family living in extreme poverty, like really struggling.
Okay.
As their income drops even lower, they might actually start buying more of something really basic and cheap, like, say, plain bread or rice.
Wait, more? Even though they have less money?
Exactly, because it's the only thing they can afford to get enough calories to survive. They can no longer afford even small amounts of slightly better food, vegetables, maybe a little meat. So as their income falls, their demand for that cheap staple increases out of sheer necessity.
Not because they suddenly love bread more.
Not at all. It's what they buy because they have to. There are no other viable options left within their tiny budget to meet that fundamental need for calories. It's compelled consumption.
Okay, I get that. Buying out of necessity when options vanish.
Hmm.
So how does that lead to a cornered good? That sounds more intense.
It is. A cornered good is a more extreme and frankly much weirder type of compelled good. This is where the logic gets turned on its head. If the price of a cornered good goes up, demand for it might, paradoxically, also go up.
Whoa, okay. Price goes up, demand goes up. That sounds completely irrational. How does that even work?
It sounds irrational by normal standards, but it makes a terrifying kind of sense if someone is truly cornered. There are two absolute must-have conditions for this. First, the item must already be a compelled good. The person is desperate, buying it out of sheer necessity, like our bread example.
Okay, necessity is key.
Condition number one. Condition number two is the really crucial part. There cannot be any viable substitutes available. Zero. None. No cheaper alternatives, no way to switch, no way to do without it, even for a short time.
Completely trapped.
Exactly. Think of like a boxer literally trapped in the corner of the ring, ropes behind him, opponent punching hard. What does he do? He can't retreat further. Often, the instinct is to lash out, to attack more aggressively, even though the pressure is increasing.
Okay, interesting analogy.
So for our cornered consumer, if the price of that absolutely essential non-substitutable good goes up, what happens? They actually become poorer in real terms. They have less purchasing power. And because they must have that good, and there are no alternatives, they're forced to cut back drastically on everything else they buy, maybe even other necessities, just to scrape together enough money to buy the required amount of that now more expensive cornered good.
So they sacrifice everything else to get enough of the one thing.
They're cornered into it. They might end up consuming more of it in a way, or at least dedicating vastly more resources to obtaining it, even as the price increases, because the negative pressure, the lack of options, overrides everything. The technical terms involve income and substitution effects, but the intuitive idea is being trapped.
And how does this relate to addiction?
Well, think about severe physical addiction. It involves compulsive drug seeking, overriding rational thought. But it's also driven by the need to avoid the intense pain and horror of withdrawal, or even just the anticipated fear of future withdrawal or inability to get the drugs.
So the drug becomes like that cornered good.
For someone in that state, absolutely. When they face uncertainty, maybe supply is tight, maybe it gets harder or riskier to obtain that desperation can intensify. It can compel them to use even more frantically when they do get it, or to go to extreme lengths to secure a supply, almost hoarding it against that future fear.
Hmm.
It's not rational pleasure seeking anymore, it's staving off disaster.
Wow. Okay. So this cornered good idea, this rational backfiring under pressure, how does that change the way we look at DSCRs? It sounds like it flips the standard arguments.
It really does, particularly for a specific group of users. Consider someone who is severely physically addicted. For them, the drug isn't a choice, it's not a luxury, it's a desperate necessity to avoid agony, it's a compelled good.
Right.
And given the realities like lack of immediate accessible detox for everyone who needs it, or medication-assisted treatment being unavailable or having waiting lists for that person, right now there might be no viable substitute.
Making the drug for them function as a cornered good.
Precisely. And this is the critical counterintuitive insight for these truly cornered individuals, trying to make it harder for them.
Like increasing the price in terms of risk, hassle, denying clean needles, forcing them into dangerous situations.
Exactly. All those things that opponents of DSCRs might see as necessary deterrents. For this specific group, those actions might paradoxically intensify their need, their desperation, and their drive to use.
Because they're cornered. They'll find a way no matter what, but it'll likely be riskier, more desperate, more harmful for everyone involved.
That's the logic, yes. So for this group, providing a DSCR isn't really encouraging use in the way we normally think about it. Their demand is already incredibly high, driven by that physical compulsion and lack of alternatives.
So the facility doesn't create the demand, it just channels it.
It channels the existing desperate behavior into a less harmful setting. Safer for them, less risk of overdose, less risk of spreading disease, and that benefits society too, right? Stops disease transmission chains, reduces public health costs down the line.
So for them, the DSCR doesn't necessarily increase their total drug use because they were maxed out on desperation anyway.
Arguably, yes. Or at least the facility simply provides a safer venue for the use that was going to happen regardless, possibly preventing even more frantic or risky behavior driven by increased difficulty or fear. It's about managing an existing, almost non-negotiable demand.
Okay, this is really shifting my perspective. So if this economic lens holds true, what does it mean for actual policy? Sounds like we can't have a one-size-fits-all approach.
That's exactly the implication. It demands nuance. For the severely addicted group, the ones we're calling cornered DSCRs, look like a highly pragmatic harm reduction strategy.
Addressing that existing intense demand in the safest way possible for everyone.
Right. It manages the unavoidable reality, prevents worse outcomes like death and disease spread, and this is important. It can act as a first point of contact, a place to build trust, offer connections to treatment when the person might be ready, which is incredibly hard to do if they're completely underground.
Okay, so for that group, DSCRs make sense from this perspective. But what about people who aren't severely addicted? Maybe people experimenting or in earlier stages.
Well, for that group, the standard logic likely does apply. If someone isn't yet severely physically dependent, if they still have some level of control or choice, then making drug use seem easier, safer, or less stigmatized could absolutely increase their consumption.
It could lower the barrier to entry or progression.
Exactly, and might pull them deeper into addiction. So for this group, the non-cornered, perhaps the arguments against enabling and normalization carry much more weight. The focus there should probably be on prevention, deterrence, making treatment readily available, and generally making it harder, not easier, to go down that path.
So it's about recognizing different populations need different interventions.
Precisely. You can't apply the same logic to someone terrified of withdrawal as you do to someone experimenting on a Saturday night.
This economic lens, the cornered goods idea, it really does move the debate beyond just DSCRs, good or bad, doesn't it?
It forces a much more nuanced conversation. It makes us look past the surface act of drug use and ask why. What are the pressures? What are the alternatives, or lack thereof? What level of desperation are we actually dealing with? Things that look irrational might be grimly logical under extreme constraint.
And that idea of rational backfiring, that trying to deter someone who is already cornered might just make them fight harder in a destructive way. That's powerful.
It shows how our standard intuitions about incentives can break down when people face severe constraints, whether it's poverty or addiction.
Understanding this, then, could help design interventions that are actually effective because they're targeted correctly.
Yes, Recognizing that one policy, like opening or closing a DSCR, could have totally different effects on different people based on their level of addiction and their available alternatives, it lets us be smarter, more precise.
It really suggests we need a more compassionate approach, perhaps, but also a more economically informed one that tries to understand the underlying behavior even when it's difficult to look at, rather than just condemn it.
hmm It's about tailoring the solution to this specific problem.
So maybe a final thought for you, the listener, to chew on. Where else might we see this? And what other policy debates or social challenges could we be stuck talking past each other because we're applying a simple one-size-fits-all logic when what's really needed is a deeper dive into how people behave when they feel truly, utterly cornered?